Thank you. The title of my talk is Boys to Men, and I'm going to be talking about male fertility preservation in childhood, adolescent, young adult cancer patients. And I want to thank Dr. Woodruff and the Oncofertility Consortium for welcoming me to speak about this. And I was reflecting on the first Oncofertility meeting that I came to, and was one of a few of us who were thinking about the boys. And this is just such an exciting afternoon to be a part of. So I'm going to reveal my age with my Boys to Men reference. But I think that I love hip hop. I'm the 90s generation. So, one thing I have learned is that boys are not little men. And that holds true if you're a hip hopper or maybe New Kids on the Block. You can see then and now, kids are not little adults. And I hope you remember that as we talk a little bit today about the special needs of this group of patients and their families. And I found this slide and I couldn't believe it. So the whole package, this kind of spoke to me about. Yes, you've got a pediatric urologist at the mic. So, what this said to me was not only are boys not little men, but also that collaboration is key. And as you saw, having someone like Dr. Alba or having a multidisciplinary team answering these complex questions is key. And that's something I've definitely learned, that you have to have the whole package. So today, hopefully, I'll convince you that boys are not little men and that male fertility preservation is important to boys and adolescents and young adults. I'll share with you the data regarding testicular effects of modern chemotherapy, and what I've learned is that they're limited, and I'll share with you what I think is needed. I'd like to introduce a novel area of investigation that I've embarked on with my own whole package team of epigenetic alterations in sperm DNA and how they've been associated with cancer treatment and with infertility, and a lot of that data being in different populations than the boys, but also transitioning that from the rat data, men are not mice, and the study that we are launching across COG, which is effects of modern chemotherapy, modern, not old school, chemotherapy regimens on spermatogenesis and steroidogenesis in adolescent and young adult osteosarcoma survivors. And hopefully some of you in the audience will activate this study at your institution. So why are boys not little men? So this might be a primer, but they're stuck in the spermatogonia phase and they're really not ready for action until puberty. And so the direct toxicity to the developing spermatogonia is a concern. In addition, the magic happens here in the seminiferous tubulars at puberty with the development of the spermatogonia. And, that whole complex interaction between the brain and the body during that time is also very susceptible to the toxic effects of cancer therapy. But what we have learned is that fertility preservation matters for boys with cancer, and especially for their parents. So this was a multi-institutional study that we at Seattle participated in, and this was a group starting at 3 months of age. It was one of the youngest conversations I had, up to about age 12, of boys with some of the most devastating diagnoses, and yet we found that the parents wanted to talk about fertility preservation, and they were willing to take the risk associated with preserving that possibility. I even wrote a small article for that Oncofertility textbook that I have in my office about how, for me, being involved in that work was life-changing as a pediatric urologist, because I saw that when I walked in the room after this family had just been told about the prognosis, about the treatment, that when I came in and said, hey, let's talk about the possibility for fatherhood, there was a little bit of hope at the end of the tunnel. And I think this is an important lesson that I've learned. I've also learned that boys will sperm bank, but you have to lead them to water. And this goes back to that question about having a process. One of the things I learned, and we have, similar to Kristen, a patient navigator, Leah, one of the things we learned that when we looked at our group of patients at Seattle Children's, and I wanted to look at their sperm analyses, I found there were no patients that I could evaluate because only 3 of those boys had sperm banked in the prior 10 years. And so we thought, well, how can we make this easier for a teenage boy to go to the sperm bank and offer a specimen? And so this paper is kind of a little bit of a how-to for those of you in the audience that are looking at creating processes for this, but it did involve having champions and a point person, people comfortable talking about it, educational materials, and an actual what to do when and how much does it cost and here are the resources. And once we did that, we found that a 10-fold increase in the number of boys that would sperm bank. Now, as we had those conversations, we realized, well, a lot of times these boys don't want to talk about sperm banking and they don't want to talk about fertility preservation. And so we asked ourselves, well, do we take no for an answer? And it's sort of like my big fat Greek wedding, you don't like meat, I give you lamb. I mean, it was sort of that same concept where, okay, you don't want to talk about it, well, let's see why you don't want to talk about it and see if we can remove some of those barriers, kind of meet them where they're at. Was it, the family didn't want to think about their son masturbating to get an ejaculate? Was it that there was concerns about delaying treatment? Was it concerns about this and that? So this was actually a bioethics collaboration, so it's interesting where my journey has taken me. But don't take no for an answer, and not that you're not going to, if they say no, you're not going to respect it, but just open the conversation and push a little further. And that really is our obligation when we're taking care of these boys and teens who are scared. And the mom will push the issue too, as you know. But we've learned also that talk is cheap, and talking about fertility preservation is not enough. And so this was a study through the Adolescent Young Adult Health Outcomes Personal Experience Collaborative through NCI, where we looked at about 500 AYAs. Actually, this was boys, men and women, and asked them, so for the boys, were you told about the risk with your cancer therapy? Now, these were patients asked at 2007, 2008, after ASCO guidelines came out in 2006. And if you were told about the risk, were you offered sperm banking? And if you were offered sperm banking, did you go to the bank? And we found that maybe 2/3 of the boys were told about the risk, and I shouldn't say boys, young men now, were told about the risk. And then even fewer were offered sperm banking, and even fewer made arrangements. And actually, just as a side point, we couldn't even look at the female group because there weren't any girls making fertility preservation arrangements. So again, that work continues to be so important. But we found that the barriers there to taking action and going to the sperm bank was education, lack of private insurance. And so we need to think about those barriers and those challenges as well moving forward. So as we talk, okay, we're supposed to bring up the topic and mention toxicity, but what is the data that we can fall back on when we're counseling these patients? And here I'm going to show you that the data is very limited, and there's truly a need for further investigation and research in this arena. So I showed this slide earlier with regards to the COG's collaborative male task force looking at the data at the time in 2012 and then establishing recommendations. And at that time we realized, again, there was limited data, there was need for research, and many of the individuals on this paper are actively engaged in ongoing research in the arena. But as I got involved in that, it led to getting involved in what I thought was an amazing experience collaborating with 25 experts from around the world to essentially harmonize our recommendations. So what we saw was that in the UK and then the Dutch and in the Scottish and then the North American, all of our recommendations were different. And so we needed to bring everyone on the same page. So we reviewed the literature, and it was sort of scary in terms of our requirements for including papers in this recommendation. When we looked on the right-hand side here for papers regarding spermatogenesis, only 7 met our inclusion criteria. And then when we looked at steroidogenesis, even fewer. And so then we had to go back into the literature search to pull out some of the articles that didn't make the first cut. The first cut was really, they're human. They talked about sperm in the study. These were, more than 20 patients, and there were actual outcome measures. Shocking. So I think that speaks to the fact that there is a limitation to the data that's available, but we did come to some consensus with regards to recommendations. And I'm sorry that this is a small slide, but I think the reference here is a nice resource. What you'll see, though, that a lot of our recommendations are level C, or that supplemental literature search, or expert opinion. And so that is why these are recommendations, but essentially the general recommendation is, individuals should be aware of the risks to spermatogenesis and its future fertility impacts, that counseling of this risk is recommended for a subset of survivors at higher risk, and then what modalities should be used. In this case, we recommended seminal analysis, but given that almost none of the papers in the literature include that data point, that we also said, well, perhaps then you can look at blood tests. And so in terms of surveillance, we said it should be at the request of the survivor. Again, these are expert opinions, and I think there's a long way to go. But I think this is one key point that I took away from this, which is not to wait. Current recommendations for the definition of infertility are trying for 12 months. And then we thought that's too long if they've tried for 6 months. So adjusting that time frame for the cancer survivor. When we looked at testosterone deficiency, I know this ties a little bit into what you've been hearing about, so I won't go into too much depth, but again, the same concept of talking about the implications of the risk and implications of testosterone deficiency. And the recommendation was monitoring growth, including height, pubertal development and progression, Tanner stage, including testicular volume for the prepubertal and peripubertal survivors, and this was mainly for those treated with radiotherapy and TBI. But I actually would argue that it should be for all survivors. But this is trying to get a bunch of countries on the same page. So they also looked at measurement of testosterone if in the postpubertal survivors, and at how frequently and how long, and then recommended referral to a pediatric endocrinologist if there are no signs of puberty by age 14 or failure of pubertal progression. And then at the very end, they said referral to a specialist in male reproductive health. And I think here we had to acknowledge the fact that there are different resources in different settings. And so this was, an andrologist, endocrinologist, urologist, these local pathways for the postpubertal survivors who were at risk, who show signs of testosterone deficiency. And this was expert opinion. So what I learned from this was how much we need to learn. And for those of you in the audience who are looking for projects, we put together a list of projects for you because these data are needed. What are the risks and the dose thresholds for impaired spermatogenesis in survivors with these modern therapies? Little is known. What is the influence now of the cyclophosphamide equivalent dose? What's the potential for recovery of spermatogenesis or testosterone deficiency? These are the questions. There's more questions. There are more questions than recommendations almost that came out of this. What is the effect of age at treatment on the risks? What is the role of genetic susceptibility in the development of this impaired spermatogenesis and steroidogenesis? What about a risk prediction algorithm? What about improved and more accessible biomarkers than seminal fluid analysis? What about the evaluation of potential psychological harm, which you've heard about this afternoon, associated with excessive screening, or not screening, or false positive results? And finally, the health benefits that could be associated with appropriate identification of testosterone deficiency. This is generalizable actually to the general male population. So a list of questions looking for answers. So this is been what I've been working on for 10 years, not all on this one project, but looking for answers and hoping to move the field forward. And I'll share with you a little bit of our preliminary work looking at epigenetic alterations in sperm DNA. So for those of you who are not familiar with epigenetics, it's different from genetics because these are molecular factors that are around the DNA that regulate the genome activity. They're independent of the DNA sequence, and they're mitotically stable. And we can see these epigenetic mechanisms and marks at different points, including DNA methylation, histone modification, chromatin structure, non-coding RNA, and RNA methylation. We know that DNA methylation plays a critical role in the development of germ cells and sperm function. And it has been shown in human spermatozoa that abnormal DNA methylation patterns have been reported in men with infertility and with low sperm counts. What's been shown in rats but not humans has been that cancer chemotherapy induces epigenetic changes in the male germ cells and their progeny. So what's been shown in rats across multiple generations is that the methylation change that occurred in the father can then be seen in the son, the grandson, and F1, F2, F3 if you're talking in mice language. And so the transgenerational inheritance effects. So we hypothesized in humans that altered sperm DNA methylation may be a biomarker for the effects of cancer chemotherapy and sperm morphology, number, and ultimately male fertility. So I share with you now some of our team members. This is the whole package in terms of our multidisciplinary team. They're sort of as cute, but they're very smart. This is the group that also was my mentors that are now my collaborators. We have the andrology lab at the University of Washington. They're actually focused on finding a male contraceptive. And so I've harnessed their experience with that and channeled it towards fertility preservation. The Fred Hutchinson Cancer Research Institute, we're part of the Seattle Cancer Care Alliance. Steve Schwartz is an epidemiologist whose expertise is in testis cancer survivors and genetic epidemiology. And then Mike I met so randomly when I was giving a talk. It was as a case scholar, I think. And he's an expert in the fungicide effects in the DNA of the sperm of steelhead fish. And so he's really your typical Northwest Seattleite who wants to save the environment. And he and I have partnered to ask the question of the ultimate endocrine disruptor, chemotherapy, and its effects on the DNA of male sperm. And so this is our preliminary data where we showed on the y-axis are the chromosomes and along the x-axis are the chromosomal size, that we show chemotherapy does impact germ cell, stem cell epigenetic programming, and that there's the potential for transmission. Now this was in a cohort of osteosarcoma survivors and age-matched controls. Why osteosarcoma? It's a nice human model for a non-germ cell tumor. They don't receive radiation to the testes. And they receive a modern therapy that includes cisplatin, which is the backbone for a lot of pediatric modern chemotherapy regimens. So based on this was provocative, as well as demonstrated the proof of principle that we can collect seminal fluid, we can evaluate methylation of the DNA, and that this is an important area of investigation. And so now I'd like to introduce you to some of our current research, which we're hoping to go from the 5 institutions that led to the preliminary data to the institutions across the Children's Oncology group. And this is our recent funding. It's a wonderful group study committee in COG that's our additional collaborators across oncology, survivorship, osteosarcoma, nursing, CRAs. I mean, really a multidisciplinary team. And so what do we hope to look at? We're hoping we can determine whether infertility and the biomarkers of spermatogenesis and steroidogenesis differ in these male osteosarcoma survivors who were treated with cisplatin, with or without the ifosfamide, which is a newer alkylating agent, compared to male controls without a history of cancer. And we want to see whether cisplatin, with or without ifosfamide for the treatment of osteosarcoma, alters sperm DNA methylation. An additional exploratory aim is looking at the genetic susceptibility and the development of these impairments. This is a study that we are activated and launching across 178 Children's Oncology Group sites. So you've probably been receiving emails from myself or Renee, the CRA, hoping you will open and enroll. And this is a cross-sectional study, so I would love to be able to look at before and after, but this is a cross-sectional assessment of those who are alive, male, are over age 18 but under 40, were previously enrolled and randomized on these collaborative trials and have not had a second malignant neoplasm and speak, read and write in English, Spanish, and we're going to hopefully expand to French for our Canadian colleagues. This is a schematic of those therapeutic studies where the patients received cisplatin at 480 milligrams per meter square with or without ifosfamide at 45 grams per meter squared, and then that was a study from the 90s. A more recent study is at cisplatin at 480 milligrams per meter squared with ifosfamide at 60 grams per meter squared. Now, one of the criticisms is they're modern, but they're already, are these the therapies that will move forward? Probably not, because advances are being made in survivorship, but this is an excellent model to look at these questions, and hopefully what we find will be generalizable to other therapies and other non-germ cell survivors. At our coordinating center, we're making it as easy as possible for a young man to participate. So once the individual has been enrolled, consented, then we take over and they collect the blood, the saliva, and the seminal fluid, and we do offer an honorarium. In parallel, through the Fred Hutch, we're trying to recruit population-based, age-matched controls through random address sampling and calling. So this was a sticking point for the NIH at the first submission, was that we could not extrapolate data from already published standards, that we had to enroll case and age-matched controls. I want to thank the team. I want to thank Teresa, who sat me down, I don't know how many years ago, and said, "You will write that R01. You will do this." And I said, okay, I can do it, I will try. And if you don't do it the first time, try again. And I hope that's a message for all of us who really believe in this work. So I hope you realize that boys are not little men, that the data is limited, but we can use those recommendations to hopefully answer the questions that remain. And I hope that our study leads to further investigative questions and maybe a few answers. So thank you.
Thanks, Margaret. That was
could you
great.
just introduce yourself
Yes.
and like what you do, because I don't know
Sure.
everybody. Okay.
Lena Nahata, I'm pediatric endocrinologist at Nationwide Children's. Thanks so much for presenting some of that great work. I think you made a great point that risk assessment is really important, and we don't know a lot about what these agents do. I think, though, at the same point, when we counsel people up front before they're getting therapy, I think it's important to realize, number one, we may know what their initial regimen is going to be, but if they don't respond well to it, or if they relapse in a short period of time, they may not have any window off of that therapy. So suddenly that low-risk therapy has now gone on to transplant or something else that's high risk, and that window to bank may be gone. So I think that's important. And then we all have been around in the very recent era where that 10 grams per meter squared of cyclophosphamide has changed to 7.5 and has changed to 4. So in a very short period of time, really. So I think all those things need to be kept in mind in that initial counseling.
Well, I really appreciate your comment, because I perceive risk very differently. Yet, to me, I went into pediatric urology because we have 97% success rates, and so when I see a 1 or 2 or 3%, that's high. But to someone else, that's low. And I think that perception of risk is really interesting. I am a big advocate of upfront fertility preservation, regardless of the risk, because I think we still don't know what's really low or what's really high, and because it's changing, because they're at risk of relapse. So with our process that I mentioned, our standardization at our institution, we said, if you're a boy and you're 12, we are going to offer sperm banking, regardless of the risk. And that's and now the challenge is, resources are not unlimited, but I think sharing the fact that this could go from low to high is really important.
Hi, I'm Anna from Brazil. My question, in fact, is for fertility preservation and males in general, not only young adults and adolescents. I know that the desirable is that you just preserve semen before any chemotherapeutic treatment. But sometimes we receive the patient already treated for 1 or more cycles. In this case, do you recommend your patients to wait a period after the last chemotherapeutic cycle before collecting because of some impact of that drug on the gametes you're going to preserve?
this is the area that we need more information on. I think better now than later. They can always do it again. I think there are clearly advances in what can be done in assisted reproductive technology to identify the healthy sperm. Actually, exactly what you're asking is what I hope to find a biomarker of with the epigenetic DMR regions. So wouldn't it be cool if we could use this panel of DMRs to identify the at-risk sperm after therapy? I don't know the answer, but I think better to try and then try again, and then it only takes one healthy sperm. A lot of times during therapy, though, as someone else brought up, and this kind of speaks to the erectile dysfunction, it's really hard to
But if
provide
it
this-
has kind of 2 or 3 days or 1 week after chemo and he's going to do another cycle only 2 weeks later, do you wait, or you just have that opportunity and you collect today and maybe another one later?
I think we know a lot about the acute injury that occurs to the developing spermatozoa during that time, because these are the same agents that are acting on the DNA to fight the cancer that are going to act on the DNA in the sperm. I know that Dr. Meistrich is in the back. He's probably going to have an additional comment regarding that. I don't know if you want to come. I'm sorry to jump, but I'm sure you have a comment to answer that.
I think for safety, if it's, say, a non-alkaline or non-platinum drug, 6 months after the end of therapy, maybe if platinum or alkylating agents are involved, 1 or 2 years. And then in terms of short term, someone needs to bank right away because he's going to do a bone marrow transplant. It depends what he's been treated with, and alkylating agents are the worst.
Yeah, and so it's a little bit of an unknown. You can play it safe by waiting, but sometimes you just can't wait. And it's a case-by-case assessment still.
Thank you.
Can I go back to this slide about all the questions that we don't have? I mean, literally when we looked at this question as a group, we couldn't find a recommendation or answer for it. These were expert opinions, and so I don't know if I can give you an answer that's supported with any rigorous evidence. I think you're safe by wait. If it's, like Dr. Meistrich said, if it's a therapeutic agent that's non-alkylating, and if they're going on TBI, it's worth trying. But if you can wait 6 months or until after therapy, that's better. That's safer. If you talk to a lot of the reproductive guys and women in the arena, they talk about not just one seminal fluid, sort of getting several over time and repeating it. And so I think you have to think about that as well. So if they get it now, maybe they can get it again and reevaluate the morphology of those sperm. This is a great question. Please, someone take that on. Yes.
Hello again. I'm Abby from Cincinnati Children's Pediatric Urology. I kind of just have a comment, also just something to be thinking about. We're doing some current retrospective studies at our institution on semen analysis since we started our Oncofertility program. And like you mentioned, the numbers are starting to look like about 50%, 47% of pubertal boys are declining to sperm bank before chemotherapy, which I think is a huge number, especially for it being something so not invasive. So I'm not sure what the number for like the front runner is on that. Is it cost? Is it because they don't want to have that conversation about their mom knowing that they're masturbating? I think it's multifactorial, but it would be interesting to know what the front runner is so that we could try to maybe approach it differently so that boys would be more open to doing it.
So I think we tried to answer that question in the NCI study of the 500 survivors. And so of the ones that were told of their risk, and then of the ones that were offered sperm banking, those who then went on to sperm bank were few. So then we asked what were the barriers to sperm banking in that cohort. And we looked at it from an access. We had several write-ins that we categorized as access, and then others that we categorized as health-related. One of the issue that came up as a barrier was lack of private insurance in terms of the access. And then this interesting theme came up around concern regarding future risk with the use of their sperm. But that was, very qualitative. We're seeing, an increase in sperm banking because of the change in culture of the providers, and it's very rarely, if you have, like you have, we have a process in place that's pretty timely. It very rarely results in a delay of therapy. That's usually not it.
Right. Well, and I've also had some pubertal boys that have shown interest in doing testicular tissue cryopreservation because they're going to be going to the operating room for a central line placement or for another reason, and I don't know that they quite understand that it's an operation, that there's a higher risk, or that they truly have much more data on sperm banking versus the testicular tissue, even though we try to highlight that it's experimental.
Yeah, we showed that in the prepubertal testis tissue paper that some religious groups actually requested the biopsy rather than an ejaculate. And actually that was honored because they understood the risk benefit. I think that's a tough area ethically.
Testicular tissue or testicular sperm?
Tissue.
Tissue.
And saying rather than having a urologist actually extract sperm and not.
You mean a TESI? Oh, this is really interesting. So this is where it comes up. So if you have a Tanner 2 boy, can he provide an ejaculate? Oh, time's up, sorry. Yes, cut me off. But go ahead.
Historically, back in the early 80s, there was a dogma that because the spermatogonia in the prepubertal testis weren't as proliferative, that children would be more resistant to chemotherapy. As data I've seen, all our data and other people's later data indicate very similar sensitivity to various chemotherapy regimens, which actually is surprising given the very different biology of the prepubertal testis. So do you think that there are any agents or cases that we can't just extrapolate adult data to try to get a rough risk estimation of future sterility in a child?
So I think what I hear you asking is, can we extrapolate data in adult men to the risk in boys? And you were like, I planted you in the audience. I think boys are not little men. And we know that there is a window of pubertal development that might be most susceptible to epigenetic changes. And I think that's what we need to learn. Thank you.